How to move it? How to move this? How to move right and left? Hello, everyone. Hello, everyone. I'm Dr. Rasha, the palliative care specialist in Burjeel Medical City, and happy to have you today. So I'm presenting my colleague Akila, who's going to present for us the role of palliative care nurse specialist. Akila is a UK-trained palliative care clinical nurse, and she has been working in the UK in NHS and hospice for more than 10 years. With her extensive and thorough experience, she came to us here in Abu Dhabi, and she is expert, and she's providing excellent education to our nurses in Burjeel Medical City, plus she's also providing consultations in and outside the hospital according to the needs of the teams and patients. Thank you very much, and Akila, you can.
Assalamu alaikum wa rahmatullahi wa barakatuhu, guys. Thank you so much for joining us today. So nice to see so many familiar faces and new faces. Thank you for taking the time out this weekend to be with us here today. We are truly so happy to be having the first palliative care conference in the UAE. So thank you for the introduction, Rasha. Just a brief sort of introduction into the clinical nurse specialist role. I think we have another colleague here, Anu, who is our nurse consultant, so you'll be hearing from the nurses. So I just want to go straight into it, but this is not working. Lovely. So this is the Derby model. It's 7 steps. So what is a clinical nurse specialist? When I first came here, it was unheard of. We are fortunate in 2022 that the PQRS for the Department of Health changed, and they are recognising practice nurses, clinical nurse specialists, and advanced nurse practitioners. As we know that the nursing movement in the UAE is still developing, it's very much in its infancy, but we are here to work together and improve. So I thought that the Derby model would be a little bit good to explain how it works, and you've just got sort of, it's very self-explanatory, I won't go through it, but you've got sort of novice, beginner, competent, and it just identifies how a nurse will graduate with a bachelor's initially, gain some experience, and then developing her knowledge in theory, whether that's from a master's degree or other workshops that she may have undertaken or fellowships, and then develop into that clinical nurse specialist role. The role isn't isolated to just a nurse specialist. We do advance into an advanced clinical practitioner role, and we are very fortunate in that we can prescribe both medical and non-medical prescribing, and eventually you can even become a nurse consultant. So initially, parts of this model were started early as 1984, and it was revised in a paper by David et al. In 2016, which was quite an interesting read. And what it actually identified was that nurses had a high level of confidence actually dealing with these patients. They knew their patients well. It reduced the impact on the doctors. It also allowed us to retain staff. One of the issues that we have is that nurses find that there is no progression, and this is super important. And so nurses given the ability to be able to spread their wings and develop clinically, it was one of the benefits of having them dealing with patients from an autonomy point of view, and also developing their learning and development. There's a few other themes that were identified as well. So like the leadership pillars, you can have nurse managers, chief nursing officers, directors. So it allowed them to see things from a sort of service point of view, how things were run operationally, and then also how things were done clinically. Nursing school is very different from medical school, and we are still learning. We are not here to replace GPs. We work supplementary to GPs, and the role is very complementary to a physician. And I think it's very important we remember that. But actually, nurses have the softer touch. We give more time to our patients, and actually we build trust a lot more easily and a lot more quickly. And we found that patients and their relatives had reduced stress, reduced anxiety, and there was a better quality of care when nurses were providing this autonomous service. And so it's developed leaps and bounds in other parts of the world, and we really hope to do that here in the UAE. So, how does my role fit in Burjeel Medical City, and what is it that I do? So this is a brief chart of some of the things that I do on a day-to-day basis. As I mentioned, I work autonomously under Dr. Neil and Dr. Rasha, and I discuss my caseload with them should I come across anything complex. It's not isolated to oncology patients alone. We see patients who will have issues with symptom control, whether that be nausea and vomiting, shortness of breath, pain most commonly, agitation, and it's quite important because our service is super busy and it is required. This allows our team to focus on our palliative patients while I can see consultations. And what it's done over the last few years, we've had a caseload of 7 patients and we've gone up to 45, so we get super, super busy. But it identifies that actually people know that the service is there and it's needed and it's required. It also enhances our collaborative working, which again is very important. Dr. Rasha mentioned how we work together with the nurses on the floor. It allows us to develop the clinical skills that we have for our nurses, and actually allows our nurses to identify what they find interesting and would they like to develop into a suitable role, such as the clinical nurse role. One of the biggest things that we've done is we've reached out to external hospitals, not sort of under the Burjeel umbrella, and we're very fortunate in that they do refer to us. You may or may not know that we have the only inpatient palliative care unit at the moment. There is another one in Dawam, but more or less in this vicinity, it's us. And so the Seha hospitals and other private facilities will refer to us, and we're very fortunate to receive those referrals. They are usually vetted by Dr. Neil or Dr. Rasha, and then I myself will go and see those patients. What is the point of that? The point is that we need to plant that seed that actually this patient is not going to be receiving any systemic anti-cancer treatment, that actually they will be for allow natural death. Now, the Allow Natural Death was published in 2016 in the UAE. It requires 3 consultant signatures. It is very much a clinician decision, but actually we always have these conversations with the family, and we like to discuss it with them and respect their values and wishes and their personal beliefs. If they choose to accept, that's great. If they choose not to accept, then obviously the patient will be for full code, full escalation. But at the time of my visit, I also get to physically see how unwell that patient is. So I think my colleague Joy, Dr. Joy, talked about IPOS. We've got the Karnofsky, the ECOG score as well. I want to know, are they suitable for transfer? We have had patients where we did not conduct a physical assessment. They were sadly transferred to us and then died within a couple of hours of coming to our facility. It's unsafe, it's unethical, and there's no symptom control. Opioids are not given in the community setting in an injectable manner. When a patient is that unwell and they're transferring, they can only receive medication by injection. And so if a patient is not fit to be transferred, we shouldn't be doing that. So it's being very open and honest. Sometimes we see families and they will want us to have a second opinion from an oncology perspective. Again, that's fine, but we won't welcome them under palliative care. We tend not to give mixed messages. We like to be open and honest about what we're saying, because it then makes it easier when they arrive. So it's all about setting the tone. I believe, and my colleagues as well believe, that 70% of palliative care is communication. The rest is medicine. It's a very small amount. We use the spikes methodology when we're having these conversations. It is not a one-off conversation. It is a conversation that has to start at early advancement of the trajectory, and it has to be repeated almost daily. It's not easy. We don't enjoy doing it, but we're here to advocate for the patient, and I think that's the most important thing to remember. So as well as my clinical role, there's also the nurse manager's role, and we have developed recently, very recently actually, the use of a PCA. That's been done by one of our sisters at the hospital, Sister Kanaga, with Dr. Rasha, and we're very fortunate to have brought that in. Prior to that, we brought in subcutaneous infusion and subcutaneous injections, along with subcutaneous fluids. So it's really trying to tie in that from a strategic point of view to see where we're going. And we are trying to head in the direction of opening our first hospice here. And so it's just working towards that, building the culture, taking away the myths, and answering those questions that the relatives, the patients, and even the staff may have, because there are a lot of taboos around palliative care, as it has been discussed earlier today, and we need to clear those myths. Education and awareness will help grow and develop palliative care in the right direction. What other examples can I give you? So during my rounds, there was somebody that had ketamine started, and we used ketamine to help manage pain. But actually this patient had raised intracranial pressure. It's a contraindication. So during these ward rounds, when we are seeing the patients, we are speaking to the GPs on the ward who are not palliative care trained. It's very important actually that we pick up these things. So that was one of the issues. Sometimes with ketamine, it can irritate the bladder lining, and so patients can get hematuria. Generally, we like to use ketamine for 5 days. So again, it's just making the nurses mindful that if there is a change, we need to be questioning why that change has occurred. Is it related to the medication? And so seeing these patients who have opioids on a daily basis is very, very important. And it doesn't even just stop there. I mean, when these nurses are giving opioid PRNs, when they are starting infusions, some of them are unsure about how to do that, which is fine. We all learn. I learn something every day. And so it's just reiterating to them that actually when we give a PRN of morphine, which is 2.5, we don't dilute it in 50 ml over an hour, because that's not going to achieve anything. Also, in regards to like setting up the infusion rate, it's over a 24-hour period. So again, it's just teaching the nurses and providing that clinical supervision in order to reach optimal pain control for the patients and ensuring that they have a better quality of life. When we achieve this, we find that actually family and friends, relatives have less anxiety, they're more comfortable with us, and they trust us because we are trying to make the days count. We are not counting the days, and I think that's really, really important. Another success story that we've had is we've been supporting the bone marrow transplant unit for a very long time now. We've recently tapped into the pediatric side of things, and we've been very successful in providing morphine and oxycodone infusions along with haloperidol to support patients who are struggling with nausea and vomiting. The BMT team weren't aware about using haloperidol for this reason, and it's something that we use second line. It was difficult in the beginning, but actually now that they understand how it works and the doctors have seen the benefit from it, they are very much welcoming. And as a result, we continue to go to MDT with the bone marrow transplant unit once a week, and we regularly get referrals from both adult and pediatric. It's not easy providing this change culture, and we have to be really patient, but I just want everybody to know that actually if we do this together, we can make a positive change. We are advocating for the patients, and change is never easy, but we have to be persistent. Sometimes nurses are good at pushing change forward. Another common issue that we get is when I'm around and about, that pain is not controlled, it's not managed, and it never seems to make sense to us. And then when we ask about their bowel movements, they've been constipated for 5 days, 6 days. You know, whenever we're prescribing opioids, it's very important that we ensure that patients have laxatives. And so these are some of the other common issues. Again, these are all examples of what's happening in the working environment to highlight to you actually that it's not easy, but it's how we learn and it's how we teach our colleagues, because we shouldn't be working in silos, we should be working together. The last example I think I can give was a 54-year-old female who had a neuroendocrine tumor. She recently came to us and she was on a 200 milligram fentanyl patch, which is equivalent to about 240 grams of IV morphine. They tried to reduce it. They reduced it to 100, which is a big drop, and they weren't successful. And actually, upon assessing the patient and seeing her, we realized that she didn't have no neuropathic agent. She was receiving chemotherapy. She's got a trach. She's ventilated. But actually, over the course of maybe 7 to 8 weeks, we've now got her down to 25 micrograms, and we've added in some gabapentin. And now the doctors are aware that actually sometimes it's not just opioid control, but we need to use adjuvant therapy in order to complement that and get the best outcome that we can. So the benefits, I think I've probably touched on that a little bit, but it's having those emotional conversations. You know, nurses sometimes can see less patients and provide that care that we need in terms of communications to the patients and the families. And it doesn't just stop there. Sometimes when we go home, patients and relatives may need that phone call, that text. We certainly don't stop our care when patients die. We try to provide bereavement telephone calls to all of our patients, maybe 6 to 8 weeks after. Sometimes it's difficult for the families to come to terms with the loss, and maybe they're not ready to speak to us. Other relatives might want to come in for coffee, and it's always a good outcome. Even if they disagreed with our treatment care or plan at the time, that's fine. But it's about supporting them with the post-bereavement effect. That's really important. And also because they will take that experience of end-of-life care to somebody else that will die in their family or a friend. And it's a fact. It's going to happen. We can't run away from it. Again, these conversations and situations are not easy to deal with, but actually we choose to do this day in, day out because we love our jobs. And it's an important part of us. And that's why having patience and communicating those needs in a sensitive way is so very important, and it has to be done continuously. Again, it's not just a one-off conversation. There was a study done by Jack and Oldham in 2002, and that was just really quite interesting about the themes that came up. So again, patients and their families were scared to try all morphine, but actually what they found was that they had better quality of life, symptoms were controlled, the patients felt like they had an advocate, you know, somebody to listen to them. It was like the professor from the US that was having the conversation with the young girl who was having diarrhea. Sometimes all they need is somebody to listen. Again, this is why I'm mentioning that 70% of palliative care is communication. That's all it takes. And also they had increased psychological output. You know, when patients have pain, we know it's a case of total pain. It's not just a physical output. There's a spiritual element. There's a psychological element. And so speaking to patients and being there for them and advocating and understanding their needs actually can help reduce those levels and anxiety, which in return can impact their symptoms. And so that's really quite important. A few other issues here. So there's a global demand for doctors, and by upskilling the nurses, it really does alleviate the pressure. Some days we are super, super busy. Nurses in the UAE at the moment cannot prescribe. Forget even prescribing narcotics, that's a whole different conversation. But actually, if our doctors are busy in clinic, it allows us to see the consultations without the doctors having to leave the room. We may ring them a couple of times, but actually it alleviates that pressure for them. Most importantly, again, upskilling the nurses. If you've got somebody who's got experience on that ward, if they're a valued member, if they work well amongst the nursing team and the doctors, it can also help to bridge that gap. As well as that, you're then expanding the service. So we're able to offer palliative care as an outpatient clinic in several locations within the UAE. Again, it's taken time and we've had to be persistent, but we've achieved a lot through it. And as a result, we have colleagues ringing us for inpatient inquiries as well, which is actually really nice. So if any of you have any inquiries or have anything that you're dealing with, please feel free to ring us. Don't shy away from it. We're very open about the help that we can provide. And I think we all learn from each other, which is very important. Another issue is palliative care very much is in its infancy in the UAE, and so we're trying to build the curriculum for that, and I think that's really important because, like Dr. Humaid said earlier on, everybody should be aware of palliative care irrespective of their diagnosis disease. From the day we're born, we're sort of counting down the days, and nobody knows how long we have. You have people that are unhealthy that die, and you have people that will just drop dead in the street. And so we always need to be prepared. And I think as healthcare professionals, that can only start when we're educated about it quite earlier on. Limitations. So we have a lack of funding, a lack of awareness. Sadly, in some places, typically patients and relatives, they want somebody in a white coat who has the doctor's title. And I think for this to work, we really have to try and move away from that. It's challenging, but it can work, and it has been proved in many places. There was another study, I'm not going to say the name or when it was done because I can't remember, but it showed that actually nurses who had the training weren't always confident and competent in delivering that care or providing that clinical skill. And so they go hand in hand. It's not just about somebody having the competency, having a piece of paper, or having taken a course for a day. This experience comes over years of practice, and that is so much more valued, and it's really quite heavy when you're in the environment and you're providing that care, because sometimes reading a textbook or attending a workshop just doesn't cut it. And so my point is that if we have people in our environment that wish to develop into that speciality, we should support them, because retention is also an issue which I've put on there. Again, working in silos, I think it helps bridge the gap between doctors and nurses, and also, you respect other people from different departments. So I think as a clinical nurse specialist, I'm very fortunate to work with a lot of colleagues from different specialities, and we learn a lot from each other. So it's all work in progress. These are my references. Thank you very much.
Thank you very much, Akila, for the nice presentation and for elaboration of the role of the palliative care nurse. And we all believe that good nursing care is the core of palliative care. And with that, we will present our colleague, Anu, who's going to present for us when is the right time to introduce palliative care. Ms. Anu Thili is a nurse specializing in palliative and alternative medicine, and she's dedicated in developing volunteer groups for palliative care in various settings in Bodentry. Thank you. We will have the questions later. Thank you.
Thank you, Dr. Resha, and thank you, Akila, for saying it out, the role of nurse. So from morning onwards, we have listened. Who needs palliative care? What is palliative care? Where can we give palliative care? And now let's have a small discussion on when is the right time to introduce palliative care. This is a real case scenario. I know I came to I met Miss Annie several years ago. Let me tell you something about her. She was 40 years when I met her. She had stage 3 breast cancer, mastectomy done, undergoing CT and radiotherapy. When we got the referral, she was unwell, fatigue. She had complaints of nausea, vomiting, feeling unwell, loss of appetite, sleep issues, not being able to do the things she used to do, her routines, her hobbies, uncertainty about the future, worry about the treatment results, fear of cancer, whether it will spread, illness and treatment information, feeling of sadness and loneliness, sexual and intimacy concerns, why me and will I die, regular things that patients on chemotherapy and radiotherapy, when they get a chance to talk with palliative care people, they used to ask. Treating the pain, symptoms, and stress of cancer and its aftermath is as important as treating its cancer. See, patients will be, juggling with the cancer-related symptoms, treatment-related issues on the top. They have psychosocial, emotional, spiritual, financial, sexual, and caregiver issue. Supportive and palliative care team collaborated with Mrs. Annie, her family, and the oncology team to create a personalized care plan. Meticulous symptom management, maximize the quality of life while managing her illness. Patient understanding of disease eases doubts and distress, informed and shared decision-making. She had less anxiety and depression, better coping skills, improved patient and caregiver satisfaction, less caregiver stress, better patient and family outcomes. In short, making every day a good day. So when to introduce palliative care? Usually, when there is nothing to do more, they tend to say, okay, next is palliative care. So you saw the difference what Annie had. Can be introduced anywhere in the continuum. Anywhere in the continuum, earlier the better. When palliative care, delivering palliative care itself is a challenge, I can understand how early introduction is, how much complex and challenging it is. Palliative care is based on the need and not the prognosis. So the need is severe health-related suffering. The right time to introduce palliative care varies based on the individual patient needs, disease progression, and personal goals. There is no specific time to offer palliative care. It can be introduced at any age, at any stage. There is no specific time duration for palliative care. It can be provided alongside the curative treatment like integrated palliative care and can start from on the time of diagnosis. Length of palliative care. Again, you can have short-term palliative care, long-term palliative care like stroke and paraplegic patients, integrative palliative care like in chemo, like they don't want it after some time, and transition to hospice. That is something like very important. So anywhere during the active therapy, during the dying. So success story of Annie is, when is the right time to introduce palliative care? The World Health Organization recommends integrating palliative care early in the course of a serious illness. Early palliative care helps in managing distressing symptoms more effectively, resulting in better comfort and outcome. Studies shows that patients receiving early palliative care live longer. We have a misconception that palliative care hastens death. It is not like that. In fact, they live longer as they experience less stress, fewer complications, and better symptom control. The patient won't only feel better, they will be able to do more and live more. How good is that? Unfortunately, 5 years later, she came back with multiple meds. She was on some rehabilitation program for lymphedema, prevention of lymphedema and all, but unfortunately, this time her main complaints were dyspnea, weight loss, anorexia. It hurts. It hurts. Everything hurts. Everywhere it hurts. Total pain. Multiple hospitalization. She had a history of multiple hospitalization. Declining of functional status. Helplessness, hopelessness, fear of death. How will I die? How will my last days? Depressed, unfinished business, guilt, fear, what happens to my kids? Not sure how to access needed health care provided and appropriate care. I remember, like in the initial days, she used to say, the entire team is concerned only about my affected organ, the images, the test, the blood test, and that was her, concerns in the initial part. But now the entire conversation has changed from supportive care, palliative care, slowly going to hospice care. We were able to provide her physical comfort, having choice and being in control, very important, being autonomy. Respect the goals and cares, person-centered approach, that's what we offer them. Open and honest conversation, something that really matters and really values. Fulfillment of wishes, being connected to family and the world outside, being spiritually connected. Reduce unnecessary hospitalization and use of healthcare services, reduce financial burden, and improved care coordination. Back in India, the financial burden is heavy. Advanced care planning. Reduced refractory symptoms because she was already under palliative care. The last rites were performed. Dignified end-of-life care in a place according to patient's wish. supports the need of the family members, caregivers, burden, grief, bereavement care, everything else, everything well addressed. So this is another phase where somebody receives palliative care. How long palliative care can last? Many families express that they wish they had sought palliative care sooner when they got the diagnosis. Palliative care is flexible and adaptable to the evolving needs of the patient. We have some kind of misconception that he is being referred to palliative care for pain, and then once pain is there, no need of palliative care. Sometimes evolving symptoms can happen, and then again. Some people go in and out of palliative care as and when needed. Some recover from their conditions and then no longer need it. Help patients live as well as they can, as long as they can, however long that may be. That's the motto. So factors that affect how long palliative care lasts: the type and stage of disease, treatment trajectory, individual needs and preferences, response to treatment, the transition care, collaboration with other care treatment, wishes about end-of-life care, family and caregiver support. The end. Palliative care should be available from the time of diagnosis, whatever the diagnosis, whether it is cancer, whether it is any hematology condition, cardiac failure, renal issues, from the diagnosis of life-threatening illness, and also depends upon the serious health-related suffering. Unfortunately, 99% of the population that needs palliative care is missed. Palliative care is a human right, need to ensure equitable access. Again, it's very challenging, it's easy to say, but can understand how challenging it is. So we all have a duty today, encourage discussions on early palliative care and integrate into the treatment plan. We all have to advocate for that. We all have to raise a voice for that. I cannot end with my favorite quote: you matter because you are you, and you matter to the end of the life. We will do all we can not only to help you die peacefully, but also to live until you die. To live until you die, and when we say that somebody matters and you matters, we have a responsibility to preserve their dignity, to preserve their integrity, to preserve comfort. And I appreciate and I wish all the best for Dr. Neil and the team for preserving dignity and improving palliative care in this region. Thank you.
Thank you very much, Anu. And now we are having Ms. Dabia Al-Bayati. Ms. Dabia is here to represent her and her family experience with the challenges of lacking palliative care and lacking access to palliative care here in the UAE. Thank you very much, Dabia, for being here.
Hello. Thank you first to Dr. Neil and Nurse Aqila for all the care and they gave me and my family during a very difficult time. I want to thank you all for having me here and for giving me the opportunity to speak today. My name is Dabia Sardar Al-Bayati, and today I want to share my experience not as a healthcare professional, but rather as a family member who witnessed firsthand the profound importance of palliative care and the impact of its absence in the UAE and our entire region. In February 2024, after months of desperately searching for answers to my father's unbearable back pain, and after months of him being repeatedly misdiagnosed, we received the devastating news that my beloved father had stage 4 cancer. This was the beginning of our journey through the healthcare system in the UAE. For the remaining short duration of my father's life, it was also when we began to encounter the painful reality of the lack of palliative care and hospice care in the UAE. My father was immediately and suddenly hospitalized, and the medical team's focus was almost entirely on treating cancer. There were tests, scans, biopsies, and discussions about chemo and radiation therapy, but little attention was given to my father, his comfort, his emotional state, or how he and us as a family were coping with the sudden and life-changing news that he was terminally ill. To make matters worse, his doctors changed frequently, often asking us to explain the situation from the very beginning, each and every time they entered into his room on a daily basis. There were conflicting opinions on treatment from doctors working in the same department in the same hospital. It led to confusion and doubt, an unbearably painful feeling that we as a family are not doing enough for my father. We were left wondering whether my father was receiving the best possible care or whether he would have been better somewhere else if he was fit to fly. For months, my father's pain was severe and overwhelming, yet it was dismissed early on as something minor. His suffering, misdiagnosis, and lack of structured information and lack of right care became a constant reminder to us that the human being behind this diagnosis was being overlooked. His emotional distress and ours only deepened as we grappled with the reality of his condition, and we as a family felt entirely helpless. We started looking for a palliative care provider to be able to get an accurate picture as to what to expect and to get precise information to help us care for my father in the appropriate way. We didn't know where to turn, where to look for help, or even what kind of care he truly needed to receive. This is when I stumbled on Dr. Neil's profile, and the only way to see him was to book my father in for a consultation, which was hard to do in his fragile condition. The next steps were painful. We had to take it upon ourselves to find a private ambulance to move him to Burjeel, which was located so far away from our family home as it's not in the center of Abu Dhabi. We immediately felt the difference in care upon admission to Burjeel Palliative Care's unit. As opposed to poking and probing my father, Dr. Neil and Nurse Aqila and the palliative care team at Burjeel were focused on caring for him diligently with utmost compassion and care. Their objective was to ensure that he was pain-free, in comfort, and living his last days on earth with dignity, surrounded by his loved ones, without limitations on number of visitors or visiting hours. Although our time with Dr. Neil and Nurse Aqila and the team at Burjeel was short, it was a massive relief to us. If there was no hope for curing him, why was my father confined to a loud, busy hospital wing? Why couldn't we bring him home? Why and have the professional care provided in a setting that was familiar and comforting to him in his last days? Why weren't the doctors aligned in their discussions about treatment? Why was there only one palliative care facility, which was so far away from our home for my mother to be able to go back and forth or to stay with my father? And perhaps most painfully, why were there visiting hours imposed on us, not at Burjeel, but at the previous hospital where we wanted to spend the most possible time with my dad? We were not allowed to do so. In the previous healthcare settings, although the nurses were wonderfully kind, they were not adequately trained to address the needs of a terminally ill patient or to support his family. There was no clear communication about how to make my late father more comfortable. He lost mobility as he was left without physiotherapy, leading to geriatric deconditioning. Weeks went without anyone suggesting basic daily care, such as oral care or physical therapy. No one guided us on how to manage his symptoms or to support him emotionally. And no one prepared us for what was coming. We were lost battling not only this disease, but the uncertainty of how to care for a man we loved and a man who gave so much to the community. When we wanted to take my father home for him to be in his environment and for his emotional and mental well-being, we struggled to find a provider in the UAE that was fully trained and equipped for the kind of home care my father needed. Instead, we were left to fend for ourselves, researching, contacting numerous providers to secure different services or equipment. A bed from here, a mattress from there, someone to install the right support in the washroom, nurses who knew how to deal with a terminally ill geriatric patient, oxygen, painkillers, Palliative care isn't about giving up. It's about focusing on the patient's quality of life. It's knowing that the person you are treating has a limited time in life. And if you plan to treat a patient who is terminally ill, then palliative care must be given the same importance. My father gave an immense amount to community, and he deserved to spend his final days in comfort, free from pain, surrounded by love, and supported by a well-equipped medical team that cared about his dignity and well-being. And we, as his family, deserved clear guidance, compassion, and support through these heart-wrenching moments. Instead, we feel that we were moving him around from place to place, trying to find the right care for him. We believe that if his quality of life hadn't deteriorated so quickly, the loss of mobility, the ability for him to care for basic needs or to enjoy parts of life, he could have lived longer, or at the very least, his last days, weeks, and months could have been spent more meaningfully with us. This is why I stand here today, to thank you for your choice of noble profession and to speak about the dire need for accessible, compassionate palliative care for every patient who is able to pay for it or not, and who is facing a life-limiting illness. We cannot continue to overlook the patient in pursuit of treating the disease. Palliative care should not be the last resort. It should be a fundamental part of the care we provide to terminally ill patients. Palliative care offers patients the dignity they deserve in their final moments, and it gives families like mine the support and peace we need to make these moments meaningful and well spent together. I hope by sharing my family story, we can encourage healthcare providers to work towards a future where no one has to endure their final days without the compassionate and specialized care they deserve. Thank you.
Thank you very much, Dabia, for this intense and emotional talk, and thank you for sharing your experience with us. As we always used to say, we in palliative care, we might not be able to add days to life, but we make sure that we're adding life to days, and we make sure that the patient are spending their life or whatever time left for them with the best quality of life possible. We hope that we can provide palliative care as maximum as we can, and it will be universal, provided to all patients, whoever needing it on time. And thank you again for sharing your experience with us. And it's time for questions. Do we have any questions for any of our speakers? No? Then I will say thank you so much. No, there is a question, yes. Yes. Yeah, please. We need a microphone, please. Yes. Yes.
It's not a question, it's a comment. It took fantastic courage for Dabia to stand up there and show us that we are failing as human beings working in the healthcare. Every single person from 0 to 99, 120, whatever, deserves to die with the best quality of life you can give, no matter what. And it shouldn't have to depend on whether you can pay or whether it's accessible. So, Dabia, I salute you and thank you for waking up our eyes and making us really see. We can do more, can't we, guys? Please, can everybody now put their hands up and make a pledge? We can do better than this.
Yes. Yes, for sure.
Do we all pledge?
Yes.
We can do better. Nobody deserves to be in the situation of Dabia's father. Agree?
Totally
agree.
Thank you very much. Thank you, Dabia. Thank you, everyone, for this emotional and intense feelings. Yes, please.
Thank you. Thank you. Just a comment. I think it's spectacular,
Yes.
the work that you're doing, Mrs. Akila, Mrs. Anu. I'm working in pediatric palliative care. Actually, we have a specialized team with my colleague Wajdan Al-Gamdi here. And when we started pediatric, because there was an oncologist that came before asking what to do. So sometimes, you see these incredible nurses, they can do a lot. Our service is actually reversed. It's a nurse-led pediatric palliative care service. And we have 2 physicians that are helping us attached to our team. One is an oncologist, actually with extra training in palliative care. So our full task is oncology, but she's a support to us for more complex cases, and most of our cases are reviewed with her. And now we have one that is working in general pediatric, but him is board certified in palliative care. But the service itself, clinic, consultation, are run by 2 clinical nurse specialists like Mrs. Akila and Mrs. Anu. So even if you do not have these board specialized pediatric palliative care, it is possible to run a service by training properly a good nurse, clinical specialists, by specialists like the one we saw today. I just wanted to make a comment for that.
Yes. Thank you. And this is exactly what Akila earlier said. 70% or more of the palliative care is provided by good nursing care. So we rely mostly on our nurses and their experience, correct? Any more comment? Yes, please. Is it working? Maybe this one.
Thank you, Ms. Davia, for going through that agony to enlighten us. I have a thought arising from what she gave us, the gift that she gave us. Maybe this is the predominant way forward. She will suffer every time reliving it, but it may also be cathartic. And maybe this would be the one agency of advocacy that can take the movement forward. Whatever we, a few crazy professionals, say will not touch people as much as that lived experience can. Thank you.
Thank you. I just want to add that Anu also went through more or less the same difficult experience, and we were just in the break talking about it. So we are all going through this at some point of time, and we need to be there supporting and helping. It's not easy, and it's not fair for anyone to go through this experience where you have the service and you are not able to access it. Tomorrow, we will be speaking about where is the services also is not available, and this is even harder. We will wait for you to elaborate this. Any more questions? Yeah, Doctor.
Yeah, thank you to all of those speakers, and it does really touch you, and it touches you when you have your own lived experience as well of what's happened. I'm a real advocate for the nurses and the nurse specialist role. We have in the UK as well consultant level nurses, and it is really important. But also I would really encourage you to think as well about your wider MDT. It's really important that you start to grow spiritual care being involved alongside you, and that's going to look different in each different locality. It's really important that your physios, your dietitians, your AHPs are also engaged in a rehabilitative approach, because it's not just about caring for someone in those last days, it's about how you really maximise their function and their ability and what they can enjoy in the time. And it is also really important that your community and your volunteers bring their arts, their other specialist skills that they've got to bring that might not be medical, might not be nursing, but are equally important in helping someone live well.
Yeah, correct. Yes, please. Oh, you will come.
Thank you all. Thank you all. Thank you all for everything that you've done and you've said and you've shared. And I want to add on to that. You walk into a hospital environment You go in for treatment, you're expecting to come out. So yes, it's fine to have that environment without music, without a warmly decorated space. In my father's experience, he loved his music, he loved his art, and we were there in that unit. Was that going to be his last 3 months? How is that fair? Why is that needed? He could have gone home and sat. I had to bring these in. So these palliative care entities, these palliative care physical units also need to have, as the doctor said before, they do need to be different. It needs to be designed differently, decorated differently. Your staff needs to be different. The physical therapists need to have an understanding. We had to get somebody from Lebanon to be able to manage my dad's, PT conditioning. So this is just an addition to add on to that and to confirm what you're saying. Thank you. Thank you.
Dobby, I have a question for you.
Yes.
With your experience and during this time since you lost your father, did you have any time that someone was talking to you about, or you need to explain to your friends about palliative care? Like, did you start spreading the awareness of palliative, the role of palliative, or you find it difficult for you to speak about it?
No, I spoke to people. So in my experience, when I met with Dr. Neil and Aqila, communication was a big part of what they were doing with us. She's absolutely right. A very thorough, clear explanation of what our options are, what our choices are, putting it all out there and allowing us to make those choices, right? Now, obviously, I spoke a lot about what our experience was and how difficult it was with these top hospitals in the UAE.
Yes.
It was very commercial, it was very transactional. It wasn't very care-oriented. And so, yes, I have spoken to a lot of my friends. And actually, just 2 days ago, I had some women in my school who are on my, the WhatsApp groups, the mothers groups, and they were asking, does anybody know of a nurse who can care for a geriatric patient? Does someone know of a physiotherapist? This should be information available from your healthcare provider. Your GP, your hospital should be providing you with it. We shouldn't be looking for this as patients and families. This is your expertise. It's your expertise.
Because there is lack of awareness, very much lack of awareness.
And we didn't find that. There was not one unified place where we can get this information. Like I said, I'd call Dubai to get a private ambulance. Why do I need to do that? To be able to get my father to a palliative care center, to be able to get a nurse, to explain to the nurse, you need to be moving my father, to just read what I need to do and come instruct these nurses and there was something wrong.
Yes.
So thank you. Thank you again for this conference. Thank you for this effort. It's much needed. We had the resources. We were able to pay for this service. And what we kept thinking is, if we were able to pay, and this is what we are getting in return, what is happening to the vulnerable? What is happening to the people who do not have these capabilities? And how are they being cared for? And they're not. Thank you.
Thank you very
everyone.
much.
Thank you.
I ask these questions because many times when we receive the patients in palliative care, we have to explain to them. People are still not familiar with the term palliative, or in Arabic, التلطيفية. We have to explain our role. It's not the place to die. It's a place to take care of a patient who's fragile, who's suffering, and to take care of all aspects of their suffering, the total pain. So thank you, Dobia, and yes, please.
Thank you. So I think all of us in this room are people who have a passion about palliative care. As professionals and as family members or people who have a lived experience, we understand it. But what is still kind of lacking and a bit challenging or frightening even for medical professionals is the lack of government initiatives and the legislation to protect us. Because certainly we want to do what is best. I think you could probably count on your fingers of one hand the number of times when a medical professional has wanted to do harm to a patient. But there is a lot of fear of being misunderstood about, like saying even about palliative care, that you are denying the patient something. And certainly, from what Ms. Dabia said, even amongst professionals within the same hospital, within even the same unit, how open you are about these things is very difficult. So I think we need to get the government, the healthcare legislation right in place to be able to provide the best care. And I think I keep advocating, as a geriatrician, we have similar problems because the language that is used is a little bit off-putting. So, in geriatrics, even the word, is not there. So we have had to go to Kibar el-Sen, which means senior citizen. Similarly, talking about dementia, you would say haraf, which is again a derogatory kind of term. So similarly, even palliative care, there are lots of misconceptions. I think we need to all work together to try and bring this, and it has to be at a whole, pan-Emirates level, not Dubai doing one thing, Abu Dhabi doing one thing. It has to be at a federal level.
Yes.
Thank you.
I hope this can happen soon. Thank you.
Yeah, it's a compliment for all the nurses, wonderful nurses who are doing a great job. So, being a son of a nurse, I have seen my mother going out of the way to help needy people, right from my childhood. She used to, whenever a poor patient comes to her, she used to, for asking for medicines and all, she will give out of her pocket. So, sometimes sacrificing our desires, but she did that, and that's a nurse. And it's not 70%. I think 100% they are doing their job, and they're providing everything. And for Dabia, it is really hard to forget all you have gone through. It's really very hard, and it's really tough when you see someone suffering the same fate as you have gone through. And we really need to think about it, and we should advocate some ways to spread palliative care and preserve the real dignity of a human being. That's all. Thank you.
Thank you very much. Thank you. Yes. So, Akila, please to the stage. Thank you very much, everyone. And now we have a short coffee break.
Each of us has a story filled with chapters. We were at the peak of happiness. Everything was going well. We're spending our summer vacation after a year filled with professional achievements. And most importantly, we're eagerly awaiting our firstborn.
Oh my goodness.
We didn't know that our routine visits to check the baby's health would mark the end of one chapter and the beginning of another.
You see the spine? Basically, the lower part of the spine is not closed. That means that the spinal cord here is completely exposed to the fluid around the baby. It is pulling the brain down, preventing.
We discovered a problem with the baby's spine and spinal cord. We were placed with many options in front of us, and we needed to pick the lesser evil out of them.
When I met Mary and Carl, they were aware of the options of either ending pregnancy or continuing pregnancy, with the consequence that this baby will be born, possibly not be able to walk for the rest of its life. We discussed the option of repairing the spina bifida inside the womb.
We had to make a swift decision. Returning home was not an option due to the risks it posed to the baby. We won't terminate.
The spina bifida is a common neural tube defect in which the spine fails to close completely. I'm just going to take the incision of the uterus, hold the baby. It's a very complex procedure and we're completely aware of the risks. It becomes an emotional responsibility to ensure that I deliver the best care. So Mary once jokingly said to me, do you ever sleep? Because whenever I text you, you're always there on your phone. And she just texts me. Shall we go and see her and her baby?
Yes, yes, of course.
Perfect, come.
Nestled within Burgil Medical City, the Kypros Nikolaides Fetal Medicine and Therapy Center proudly stands as the first of its kind in the Middle East and North Africa. Our center specializes in precise clinical diagnostics, aiming to detect and diagnose fetal anomalies as early as 14 to 16 weeks. With state-of-the-art technology, we are pioneers in performing in utero spinal cord repair surgeries, setting new benchmarks for fetal care in the region. At Burgil Medical City, our dedicated team is committed to offering expecting parents the best options and striving for the healthiest outcomes for their growing families. Because every new life deserves the finest in fetal medicine and compassionate care. BMC, Burgil Medical City, getting you ready for life.
At Burgil Cancer Institute, we offer a full spectrum of oncology services, including early detection, advanced diagnostics, radiation and surgical treatments, and palliative care. Our success rates stand shoulder to shoulder with the world's leading institutes. With cutting-edge technology and a commitment to personalized care, we've made substantial strides in enhancing patient outcomes and quality of life. Burgil Medical City is also proud to feature the ExactTrack dynamic treatment technology. This innovative system allows for real-time patient positioning and monitoring, integrating surface, thermal and X-ray tracking with sub-millimeter precision. We also offer pediatric radiation therapy and meticulous bone marrow transplant planning. with the latest body irradiation techniques. Our expert team works in close collaboration with renowned regional and international centres. This technology is integral to our advanced radiotherapy programme, enabling our specialised staff to deliver unparalleled cancer care with state-of-the-art tools. Because every journey towards a cancer-free life deserves the utmost in oncology care. BMC, Burjil Medical City, getting you ready for life.
At Burjil Medical City, we lead the way in paediatric orthopaedics, handling complex cases with exceptional success and minimal complications. The Paley Middle East Clinic stands at the forefront of innovation, offering groundbreaking care throughout the region. Our mission is simple: to transform young lives through cutting-edge orthopaedic solutions. Whether addressing congenital issues or post-traumatic conditions, we excel in limb lengthening, deformity correction, and more. Committed to reconstruction over amputation, our expert team delivers personalised care tailored to each child's needs. We have achieved a remarkable reduction in complications for children with congenital, growth-related and post-injury conditions, enabling them to thrive and lead fulfilling lives. Because every child embarking on their journey deserves the finest expertise in paediatric orthopaedic care. BMC, Burjil Medical City, getting you ready for life.
At Burjil Medical City, we are at the forefront of robotic surgery, leveraging cutting-edge technology to handle over 80% of surgical procedures with unparalleled precision. Our specialists use the state-of-the-art Da Vinci Xi surgical system, enabling complex operations with exceptional accuracy. This advanced technology provides 3D comprehensive vision and highly dexterous robotic arms, ensuring surgeries are performed with supreme precision, care, and efficiency. Patients benefit from minimized surgical intervention, leading to quicker recoveries and shorter hospital stays. Plus, Burjil Medical City offers extensive rehabilitation and physiotherapy services to support every step of your recovery journey, because every surgical journey towards a better life deserves the pinnacle of precision and care. BMC, Burjil Medical City, getting you ready for life.
Mariam worked hard to establish her company, and the idea of giving up never crossed her mind. Every moment was crucial in bringing Mariam back to her life and her work. Our medical team at Burjil Medical City knew that Mariam's case was sensitive, especially since the type of cancer she had was rare and needed to be addressed as quickly as possible. For this, our specialists in gynecologic oncology relied on minimally invasive robotic surgery to remove the cancerous tumor, ensuring high precision, reduced pain, and rapid recovery. After comprehensive analyses and examinations, we scheduled Mariam for advanced radiation therapy sessions to eliminate any remaining cancer cells. The moment Mariam re-entered the company premises is one that no one will ever forget. BMC, Burjil Medical City, getting you ready for life.
The wedding of Saeed's first granddaughter was approaching, but severe gastric volvulus had overshadowed his joy. We were racing against time to bring him back to his life and home. The medical team at Burjil Medical City was prepared for Saeed's complex case. To address it, we performed a precise and minimally invasive robotic surgery for subtotal gastrectomy, removal of the surrounding lymph nodes, and accurate reconnection of the digestive system. This approach accelerated the healing process and allowed Saeed to regain all normal digestive functions. Thanks to our deep expertise and advanced surgical techniques, we were able to restore Saeed's happiness. Everyone turned to look at Saeed with joy, surprise, and amazement as they saw him standing. In that moment, their happiness was complete. BMC Burjil Medical City, getting you ready for life.
Hamdan's dream of winning again seemed unimaginable. Every second mattered in returning Hamdan to his life and passion. The medical team at Burjil Medical City was aware that the fracture near Hamdan's knee had affected his growth, causing his leg to become shorter and more curved over time. To address this, our paediatric orthopedic surgeons inserted a precise intermedullary nail into the bone to straighten and gradually lengthen the leg until it matched the other leg within just a few weeks. Followed by a customized rehabilitation program, Hamdan was able to resume most of his activities within 3 months. The moment Hamdan stepped back on the pitch, it was a victory before the victory. And now, everyone knew who the school's new top scorer would be. BMC, Burjil Medical City, getting you ready for life.
Each of us has a story filled with chapters. We were at the peak of happiness. Everything was going well. We're spending our summer vacation after a year filled with professional achievements. And most importantly, we're eagerly awaiting our firstborn.
Oh my goodness.
We didn't know that our routine visits to check the baby's health would mark the end of one chapter and the beginning of another.
Can you see the spine? Basically, the lower part of the spine is not closed. That means that the spinal cord here is completely exposed to the fluid around the baby. It is pulling the brain down, preventing.
We discovered a problem with the baby's spine and spinal cord. We were placed with many options in front of us, and we needed to pick the lesser evil out of them.
When I met Mary and Carl, they were aware of the options of either ending pregnancy or continuing pregnancy, with the consequence that this baby will be born, possibly not be able to walk for the rest of its life. We discussed the option of repairing the spina bifida inside the womb.
We had to make a swift decision. Returning home was not an option due to the risks it posed to the baby. We won't terminate.
Spina bifida is a common neural tube defect in which the spine fails to close completely. I'm just going to take the incision of the uterus, hold the baby. It's a very complex procedure and we're completely aware of the risks. It becomes an emotional responsibility to ensure that I deliver the best care. Mary once jokingly said to me, do you ever sleep? Because whenever I text you, you're always there on your phone. And she just texts me. Shall we go and see her and her baby?
Yes, yes, of course.
Perfect, come.
Nestled within Burjil Medical City, the Kypros Nikolaides Fetal Medicine and Therapy Center proudly stands as the first of its kind in the Middle East and North Africa. Our center specializes in precise clinical diagnostics, aiming to detect and diagnose fetal anomalies as early as 14 to 16 weeks. With state-of-the-art technology, we are pioneers in performing in utero spinal cord repair surgeries, setting new benchmarks for fetal care in the region. At Burjil Medical City, our dedicated team is committed to offering expecting parents the best options and striving for the healthiest outcomes for their growing families. Because every new life deserves the finest in fetal medicine and compassionate care. BMC, Burjil Medical City, getting you ready for life.
At Burjeel Cancer Institute, we offer a full spectrum of oncology services, including early detection, advanced diagnostics, radiation and surgical treatments, and palliative care. Our success rate stands shoulder to shoulder with the world's leading institutes. With cutting-edge technology and a commitment to personalised care, we've made substantial strides in enhancing patient outcomes and quality of life. Burjeel Medical City is also proud to feature the ExactTrack dynamic treatment technology. This innovative system allows for real-time patient positioning and monitoring, integrating surface, thermal and X-ray tracking with sub-millimetre precision. We also offer paediatric radiation therapy and meticulous bone marrow transplant planning with the latest body irradiation techniques. Our expert team works in close collaboration with renowned regional and international centres. This technology is integral to our advanced radiotherapy programme, enabling our specialised staff to deliver unparalleled cancer care with state-of-the-art tools. Because every journey towards a cancer-free life deserves the utmost in oncology care. BMC, Burjeel Medical City, getting you ready for life.
At Burjeel Medical City, we lead the way in paediatric orthopedics, handling complex cases with exceptional success and minimal complications. The Paley Middle East Clinic stands at the forefront of innovation, offering groundbreaking care throughout the region. Our mission is simple: to transform young lives through cutting-edge orthopedic solutions. Whether addressing congenital issues or post-traumatic conditions, we excel in limb lengthening, deformity correction, and more. Committed to reconstruction over amputation, our expert team delivers personalised care tailored to each child's needs. We have achieved a remarkable reduction in complications for children with congenital, growth-related and post-injury conditions, enabling them to thrive and lead fulfilling lives. Because every child embarking on their journey deserves the finest expertise in paediatric orthopedic care. BMC, Burjeel Medical City, getting you ready for life.
At Burjeel Medical City, we are at the forefront of robotic surgery, leveraging cutting-edge technology to handle over 80% of surgical procedures with unparalleled precision. Our specialists use the state-of-the-art Da Vinci Xi surgical system, enabling complex operations with exceptional accuracy. This advanced technology provides 3D comprehensive vision and highly dexterous robotic arms, ensuring surgeries are performed with supreme precision, care and efficiency. Patients benefit from minimized surgical intervention, leading to quicker recoveries and shorter hospital stays. Plus, Burjeel Medical City offers extensive rehabilitation and physiotherapy services to support every step of your recovery journey, because every surgical journey towards a better life deserves the pinnacle of precision and care. BMC, Burjeel Medical City, getting you ready for life.
Mariam worked hard to establish her company, and the idea of giving up never crossed her mind. Every moment was crucial in bringing Mariam back to her life and her work. Our medical team at Burjeel Medical City knew that Mariam's case was sensitive, especially since the type of cancer she had was rare and needed to be addressed as quickly as possible. For this, our specialists in gynecologic oncology relied on minimally invasive robotic surgery to remove the cancerous tumor, ensuring high precision, reduced pain, and rapid recovery. After comprehensive analyses and examinations, we scheduled Mariam for advanced radiation therapy sessions to eliminate any remaining cancer cells. The moment Mariam re-entered the company premises is one that no one will ever forget. BMC, Burjeel Medical City, getting you ready for life.
The wedding of Saeed's first granddaughter was approaching, but severe gastric volvulus had overshadowed his joy. We were racing.
Hello. I think we'll get started straight away because it's the fourth session of the day. I'm Katie Sweeting. I'm a palliative care consultant, recently started at Mediclinic Parkview Hospital, previously set up the palliative care service at Mediclinic City Hospital, and it's a great privilege to be here, and for me personally very exciting to see this first Emirates Palliative Care Conference out of the basement of oncology conferences and into this beautiful room of our own. So thank you, Dr. Neil and Bajil, for setting this up and making it happen. So without further ado, I will introduce our first speaker, who is my colleague and friend, Dr. Neil Najwan. Neil is a UK-trained consultant in palliative medicine. You've all seen him on the stage at various intervals today. He was trained at King's College London and worked as a consultant and clinical lead at Imperial College. He was the first licensed palliative care consultant in Abu Dhabi and works for Bajil and emphasises symptom control for better patient and family outcomes. So without further ado, Neil, I welcome you to the stage.
Thank you very much. Thank you everybody for hanging around for after lunch. Well done, you've made it through to the last session. Okay, we have how much? 10 minutes? Okay. So this is where I work. This is Bajil Medical City in Abu Dhabi. So we look forward to seeing as many of you that would like to visit as possible. How do I move it? Is it this way? There we go. Okay, so this is meant to be a very short talk on the status of palliative care development in the UAE. This is almost preaching to the choir. I think everybody in the room knows what palliative care is, for the most part. Everybody understands the benefits. This is the seminal paper from 2010, Jennifer Temmel at Mass General, where they demonstrated the benefits of palliative care. And for a lot of people, this was the paper that brought awareness to the general public that actually palliative care doesn't shorten life. Actually, you live a little bit longer if you get early enough palliative care. And this backs up what we see for those of us who've trained and worked in hospices. Patients are deteriorating really rapidly. They get admitted to the hospice. We simplify medications, improve care, and we end up discharging these patients. So this is something that we have seen, but it's nice to have it evidenced. So this is just setting the scene. This is what we would like, but we are not there yet. So the UAE is a pretty small place. I've forgotten the exact square kilometers, but the UAE population is just around 10 million. 15% of that population is local Emirati populations, with the bulk of the rest of the population being made up from expats from around the world. This has a direct correlation with the type of patients we see in the UAE. So we've heard a lot from people working in other parts of the world today. If I just think about my experience in the UK versus my experience here, I don't see very many older patients here. We tend to see predominantly cancer patients, but I don't see patients with end-stage COPD. Don't see many patients with heart failure, but we are starting to see more patients with dementia, or they don't necessarily refer to palliative care. So the population is different. For a population of 10 million, we really don't have very many palliative care trained professionals. There are about 9 palliative care doctors, and my definition of palliative care doctor is any doctor working in the UAE that has some specialty level palliative care training. We've had a recent influx of people recently, so this may be a little bit out of date, but I'm also aware that the total number of palliative care nurses in the country is also quite low. I think it's 4. I think this is accurate. So clearly we have a workforce limitation issue. This I've stolen from a publication we did last year or year before, and this is just giving sorry, the timeline. So yes, this is a Bajil-sponsored conference, but you'll generally find palliative care doctors are not so territorial about who their employers are. We tend to focus more on helping the patient. So let us be very, very clear. The first place that had palliative care professionals was Tawam Hospital in Al Ain. None of the team are here. I don't think I've seen them. One of them? Okay, none are here. So I would say Dr. Nandan, Dr. Javed, Afroz, these are our colleagues in Tawam. They're not here, but these guys have actually been providing palliative care since, I think, 2007, 2009. So Tawam was the first. Quite a number of years later, the American Hospital in Dubai, where Dr. Mona Tareen worked, they started after that. Mona is now in Cleveland Clinic, Abu Dhabi. After American Hospital Dubai, Mediclinic in Dubai, that's where Dr. Katie was working and is now working again. And then in 2021, we set up the palliative care service in BMC, Burjeel Medical City. And then last year or the year before, Dr. Mona started at Cleveland. So if you look at all of these places, the palliative care service, whether it's an inpatient service, outpatient service, inpatient beds, outreach, they're all clustered around oncology providers. This is the one common theme. This makes sense. This is where the bulk of your patients are going to come from when your services are developing. It's not all bad. BMC is an ESMO designated center for integrated oncology and palliative care, and is the only ESMO dedicated center in the Middle East. And we recently, as in last week, had our CAF accreditation for cancer rehabilitation. So thank you, Rita, and all the team at CAF. And also thank you, CAF, for being one of our sponsors today. Tawam also very recently had their JCI accreditation for a number of their specialties, including palliative care. So there is progress. Now, if we are talking about palliative care development, we should have some sort of objective measure. And this is taken from a WHO document regarding, how do you assess palliative care development? This is the integrated health service model. And based on that, there are a number of components that are probably useful to sort of try and stratify where the UAE is. So if you start at the top, do we have any health policies related to palliative care? No. The one document that includes palliative care within the UAE is a proposed cancer control document at the federal level. There's no nationalized palliative care guideline. This is something that many of us in the palliative care community are talking about. So this is work to be done. Use of essential medicines. I will come on to this. There are huge issues with procurement, accessibility, prescribing these medicines, even in the UAE. So I have a slide specifically about this. Is palliative care provided in an integrated way? No, it really isn't. As the previous slide showed, palliative care has typically been provided by providers that have significantly sized oncology programs. But palliative care is not just for patients with cancer. What about the patients with terminal organ disease, patients with frailty, or geriatric patients? So we are missing a trick. Education and training, again, there is a slide specifically for this, but there is some, but it is patchy and it is not integrated. Research, I did a PubMed search yesterday looking at palliative care UAE, 38 publications in total. So there is some work being done, but it is again at a very low level. And empowered people and communities as the last component, no. So we don't have this system or this culture of community engagement. And as a result, there is very, very low levels of death literacy in the UAE. Now, there are many reasons for that, but clearly this is a problem. So those are the components. Those are the areas that we benchmark ourselves against. But there have been some developments. Akila touched on this in her presentation. Since 2016, there has been a medical liability law that provides for allowing natural death. This means that for people who meet the specific criteria listed here, you are allowed to allow death to take place naturally by not subjecting the patient to CPR. It is important to note that it's great, but it's not enough. So we often end up with a situation where patients meet the criteria for allow natural death. Yes, this is a clinical decision, but the medical legal framework that we operate within, that operates within the UAE, is not robust or specific or explicit enough to protect doctors. So if we make this decision and the family change their mind, which happens in about 10% of the cases that we look after, these patients will get escalated, and hospital management will not support you if you insist on maintaining that do not resuscitate. So this is not ideal. The UAE is a young country. We're sort of 52 years old, so it will take time, but therein lies an opportunity. We've seen how things are done in around the world. Many of us have come from other environments, so there's something about pulling best practices together and tailoring it to the environment here. So there is work to be done, and the Department of Health in Abu Dhabi is aware of this. Incorporating palliative care education into either medical undergraduate or nursing undergraduate programs. Now, I apologize if I have missed the nursing, but as far as I'm aware, it's not integrated into any nursing program in the Gulf, or sorry, in the UAE. Medical school, Khalifa University did have a program. Their medical program is unfortunately being wound down, and candidates have been allocated elsewhere, so that program has shut. But MBR, University in Dubai, does have palliative care included and incorporated, and GMU, very thankfully, has agreed, and I'm doing some teaching at GMU. So there is some movement. This is on a background of a total of 7 medical schools in the UAE. We touched on this, access to essential palliative care medicines. This is the list of the IHPC essential palliative care medicines list. And again, I have an Abu Dhabi bias. So this is everything that we have access to in Abu Dhabi. We really do have access to everything except levomepromazine. It wasn't on formulary, no one was bringing it in. When I got here, we requested it, and because of the crisis in Ukraine, that has completely shut our supply. So we're not able to get any more. But everything else we have access to, thankfully. This is not the situation across the UAE. All 7 Emirates have slightly different procedures for procuring opioids. Abu Dhabi, very straightforward. Department of Health has a pharmaceutical opioid procurement section. They order medications. We submit a quota annually, and we get what we ask for. We don't necessarily get as much as we ask for, and there are many reasons for that, but we get. Dubai, the process is different. Sharjah, the process is different. Ras Al Khaimah, I don't even know what the process is. So this is not to criticize, it's just to highlight that we don't have a unified system, and clearly this is something that could actually, if addressed, make a huge difference. I didn't put this on a slide, but one issue is the access to these medicines. The other issue is which doctors are allowed to prescribe them. Consultants are allowed to prescribe for a period of a month in clinic, specialists for 2 weeks. So it's not straightforward. Now, I don't like saying problems. Challenge is a much better phrase. We have a number of slides. So cultural attitudes. These things are not unique to the UAE. There's huge expectation mismatch. Oops, sorry. Being sick in this part of the world often translates to this requires care in hospital. And I can understand that. What do we have access to? We have hospitals and we have home. There's nothing in between. So no wonder people say, well, you know, mom is sick, where else do we go? Okay, we have that recognition, but now we need to start thinking, well, okay, there must be some way of stepping down these patients. Again, that infrastructure is not there, and because that infrastructure is not there, there's no way of paying for it. So this is another issue. And again, I've put phrases that I've come across in day-to-day practice that I'm sure everybody else has as well. And you know, the crux of the matter is we have an expectation mismatch. So, you know, if families are thinking this is the reality, and reality is all the way down here, the wider that gap, the more the suffering. And this applies in life, and it certainly applies in palliative care. So this will take some time to change, but again, numerous people have said this morning, what we need to do is raise societal awareness as a first step. Death literacy. I'm really amazed by how bad death literacy is in the UAE. Every culture in the world pretty much says the same thing. It is a uniquely human experience. This is not rocket science. But I'm amazed by how many people say, well, look, we have the faith, we understand everything comes from God, but then you say, but then you must be able to do something. Why aren't you sending them to ICU? So this is not a criticism. This doesn't mean that people can't think freely and have an opinion, but there is a difference between, what they say and what they do, and this results in increased suffering for our patients. Because there is this expectation mismatch, you have to ask yourself, well, where does this mismatch come from? In the UAE, because we have developed at such a phenomenal rate, 50 years, this phrase, tent to skyscraper, is often used when they talk about UAE, Saudi, Bahrain, developed places in the Gulf. So there is this outrageous expectation that medicine can fix everything. I've had relatives say to me in all seriousness, well, Dr. Neil, what I think you should do, with all humility, is you go back to medical school, get your professor to teach you how to do a brain transplant, then you come back and you give my wife a new brain. Serious. So I say, right, it's not going to work, but there is a real lack of understanding as to what is possible. Medicine cannot fix everything. We're very good at coming up with drugs to treat conditions, but are we still so arrogant to believe that medicine can fix everything? It cannot. This is life. So death literacy is a huge challenge. And again, 2 or 3 presentations have already touched on the myths of palliative care. I will say within our little ecosystem, within 4 or 5 years, within our hospital, things are definitely changing. So ICU teams across Burjeel call us for advice. Surgeons call us for advice. Theaters call us for advice when the anesthetists are struggling with pain relief. So there is some recognition that actually palliative care has a skill set that is unique, and not only unique, but helpful and applicable. Wherever there is a need, if people are struggling, the standard treatments don't work, pick up the phone, ask us. And then this is the huge elephant in the room. We have a private healthcare reimbursement model in the Gulf. In fact, most of the Gulf. A number of years ago, there was a very clear demarcation between government health services and private. Now, the world is going private, unfortunately. Palliative care in the UAE is not explicitly covered in any of the reimbursement models, which is a real problem. Even in premium policies, we're talking AXA, high-end Bupa Platinum, it's not covered. It's an exemption. If patients are admitted to the ward under the care of the oncologists, CA pancreas, neutropenic, whatever, Dr. Neil, Akila, Rasha, can you go see this patient, help with their pain? No problem. We can't bill for it. So this is all sort of, this activity is there, but we're not able to generate a financial footprint. We have this model of long-term care, and long-term care sort of fills the gap between hospital and home. The reality is what you get with long-term care is you get patients who don't necessarily have an acute medical problem, but they have chronic, debilitating conditions, and these patients often have respiratory failure. So and this is not a criticism, this is an observation, the model for long-term care is that these patients these providers prioritize ventilated patients because the reimbursement is much higher. So this incentivizes intubation and ventilation of patients who are dying naturally, which prolongs suffering. So again, these are the things we have to deal with. I have 2 case studies to sort of illustrate the point. They're very wordy because I did my slides last minute, but you'll get the point. Very frail, 65-year-old gentleman, advanced bowel cancer, mets everywhere, comes into the ED, febrile, out of breath, in pain, global decline, family struggling to look after him. Stabilized in ED, pain responds beautifully for IV morphine, admitted under medical oncology, we get everything sorted out. Family are aligned with palliative care, they don't want CPR, they don't want ICU, they want him to be at home. He's symptom-free on a very low-dose morphine haloperidol infusion, but the rules of the country are such that we are not able to send him home with an infusion because we're not allowed to prescribe morphine out of the hospital. Easy fix, we're not allowed to do it. Problem number 1. Same patient, slightly different demographics, he's now an expatriate. He's worked in the UAE for 25, 30 years. Same presentation, Everything settles down. He improves on oral morphine, so actually things are a little bit better. His employer is continuing to support him financially. They've extended his residence visa, very nicely extended his medical insurance, but he's unwell enough that he needs to be cared for. Doesn't need hospital, but needs care. His employer has a hostel, bunk beds, 14 people in a big room. It's not appropriate. So this gentleman stayed inpatient under our care for 2.5 months. So a huge length of stay, financial, big red footprint. So he's unable to be cared for at home. There's no community-based services. And then the kind of nail in the coffin is that he doesn't satisfy the clinical or the financial criteria for LTC. So there are patients falling through the gaps. And this is really painful to deal with, because in the UAE, we are a high-income country, but this sort of suffering still happens. This will get better, but it won't get better until the regulators and the people who make decisions see this. So we can and we must make things better. I think that's been very, very clear throughout all the sessions today. A big part of that, I think, will be educating the public, educating colleagues, educating the community. And I'm glad to say that we do have a partnership with St. Christopher's, which we started almost a year ago, so very slow progress. But we are progressing, and hopefully the next step will be to start doing some more focused educational programs, targeting, I guess, all areas, so healthcare providers, carers, and people in the community. So there is a will, there is some financial commitment required, but again, we are slowly getting there. What do we want? So this people who've heard me over the years know that I use this slide in almost every talk that I give. Because for me, this is like the gold standard. This is what I would want. So this is a gentleman called Ronald. He was a diplomat, worked for many, many years. This is in the Caribbean. He had CA pancreas, really nasty pain, cared for by his son. I saw him at home, got his pain managed, but then he started deteriorating, couldn't take things orally. And so the issue wasn't so much the pain control. The fact was Ronald's daily routine for 30-odd years was that before he would go to the office, he would go outside in his back garden and have a wet shave under his big pui tree, it's a flower tree in the Caribbean. He wasn't able to do that. His son wasn't able to do that. So he actually said to me, Doc, the pain is one thing, but I can't do anything for my dad. I can't care for him. We admitted him within 6 hours. His pain was well controlled and very, very low dose morphine infusion. And more importantly, every morning his son drove the 20 minutes, came up to the hospice, wheeled Dad out under the tree in the back garden of the hospice, and he had a hot shave every morning for the last 2.5 weeks before he passed away very peacefully. Simple things, not difficult. I can't do this in hospital. This is so frustrating. Powers that be understand, but the way healthcare is structured and focused means that this is not a priority. It actually doesn't cost anything. It's actually very, very low cost. And again, this is the problem with the current health-based systems, which is why value-based healthcare is going to be more and more on the agenda. And I have to say, Bajil has recognized this, and there is a plan for a value-based healthcare model as a pilot within the UAE, and we are also looking at doing this within Saudi. So I have to say thank you to Bajil, not because they pay my salary, but there is quite a lot of forward thinking in terms of not just providing the medicines and a bed, but thinking about how we pay for services. So slowly. This is very aspirational. You know, I don't think a hospice is the answer to all the problems, but it can be one of the answers and one of the things that we do to try and make things better. We heard from Dr. Ross that palliative care services in the UK are under threat because the bulk of the funding comes from the charitable sector. So is it appropriate to just copy and paste that model elsewhere? No. However, the way things work in the UAE is that you need to, if you have an idea, you build something, demonstrate the value, and then the decision makers buy into it. So, you know, what do I want? I want a hospice in a very nice location, maybe overlooking Sheikh Zayed Mosque, having a place which qualitatively feels different, where you can still provide really excellent care, but it doesn't feel like a hospital. This can be the focal point for palliative care within the country. Again, this is not an easy sell in an environment where healthcare is a commodity. But I have to say, 2 weeks ago, we met with some private donors, and we've had a commitment that they will do the fundraising and raise money for a hospice. So we're in the very early stages of this, but if this is the only thing I achieve working in the UAE, I'd be so happy, just to demonstrate the value. And people say, well, you know, this isn't going to work with UAE culture. I disagree. People said UAE citizens and patients will not accept a DNAR. Rubbish. 85% of them do. They won't take opioids. Rubbish. They very much do. We are not that different. As Dr. Rajagopal was saying, there are far more similarities with all of us, regardless of the geographical parts of the world. It's always about how you frame the thing you're trying to sell. So there's always something about the way you frame your conversation. Yeah? Communication is everything. So I've slightly digressed. And anyway, this is Burjeel Medical City, but that's a very, very quick update as to where things are in the UAE. Thank you so much.
There'll be time for questions. Oh, he's taller than me. There'll be time for questions at the end. We'll move on to Dr. Mohammed Hamadeh, who's a consultant in palliative medicine in Riyadh, in Saudi Arabia. He has got extensive experience in various clinical settings, completed medical school in Paris, trained in family medicine, geriatrics and palliative care, and has held various leadership roles in the French public sector, before moving to the Oncology Centre, Princess Noura Oncology Centre in the Kingdom of Saudi Arabia. He contributes to patient care and medical education, and as the Programme Director for the Palliative Medicine Fellowship. He's passionate about medical ethics and education, and led the first Palliative Medicine Research Day in the Kingdom of Saudi Arabia. So without further ado, I welcome Dr. Mohammed, my friend, to the stage. Thank you.
Is the screen working? Here? Can we get the screen? Yes? Good afternoon, everyone, and thank you for having me. Thanks, Dr. Katie, for this lovely introduction. I don't know how we move forward with this one. So today we're going to talk about the palliative care and geriatrics. So before we dive into today's discussion, I would like to start with this clinical scenario. Imagine that you are 85 years old, struggling with memory loss and daily activities that once seemed simple, and you rely on your aging son, who is 62 years old, who also has his own health challenges. You rely on him to help you dress, eat, and even remember your name. Unfortunately, this is a situation of so many people worldwide, and this situation may touch us personally in the future with the global rise of aging population and the serious health suffering. So the question of today is, with the growing aging population, how can we provide compassionate, comprehensive care, ensuring dignity and quality of life for both patients and their families? So worldwide, there's a growing need for geriatrics, palliative care, because if we focus our care in palliative care around oncology patients that most of us do here in the region, we fail to our duty of providing equitable care, because palliative care benefits all patients facing any serious illness across all age groups. And globally, there is an increase of the burden of serious health suffering. And if we have a look to this data at the left, we can see that cerebrovascular disease is ranked third cause of serious health suffering, and dementia is responsible about 9% of the serious health suffering cases. And in addition, the aging population is going to increase, and with this, the majority of this population is expected to suffer from cognitive decline, particularly dementia. So today and in the future, palliative care will be interlinked to geriatrics and must address the complex needs of the elderly. So let's explore together the complexities in the geriatric setting. So the complexities in the geriatric population may be due to physiological changes, to multimorbidity, to the atypical presentation of the disease, and there's a complex interaction between medical, social, and mental health issues. The prevalence of multimorbidity in the elderly is important and can vary from 55% to 83% according to the population, but globally most of the elderly patients have 3 or more chronic conditions. The multimorbidity comes with an impact because it's associated with a higher prevalence of depression, increased functional decline, lower scores of quality of life, including the physical and the emotional components of the quality of life scores. Another aspect of complexity in the elderly is the disease trajectory. In fact, in contrast with younger populations where there's only a single disease or single serious illness, in elderly patients, the serious illness may have a long trajectory, and it means they may have a long period of suffering. Another aspect of complexities in the elderly is the atypical presentation in the elderly, which can complicate the diagnosis and the treatment of the patients. So older patients may often present with non-specific symptoms. This is due to multi-organ degenerative disorders. Also, they can be on multiple medications, on polypharmacy. And this causes challenges in the diagnosis. Atypical presentations are often a source of or a cause of underdiagnosis or overdiagnosis. For example, a patient who has a lower back pain or a leg pain, it can be associated with a regular symptom in elderly patients. Many elderly patients has pain, but also if we don't dig further, it can hide serious illness like a myeloma or a metastatic lesion. Another aspect of the elderly patients is their vulnerability. Data shows, or studies shows that elder youth experience elder abuse. Around 1 in 6 elderly individuals experience abuse, and it often comes by their caregivers. Another aspect of vulnerability is the untreated distress at the end of life. The last years of life is often associated with untreated physical distress, and this can be seen with the high prevalence of pain in the elderly patients. If we want to zoom about the pain in the elderly patients, we see that often pain is whether undertreated or sometimes untreated. This number of 26% of elderly oncology patients in nursing home with daily pain who receive no analgesics is simply heartbreaking. Pain is often untreated or undertreated because of several reasons. This may be the challenges in history taking, or in the common belief that pain is a normal part of aging, or the fear of opioids and medication, and the physical changes that can complicate the assessment of pain. Another major complexity in the elderly patient is polypharmacy. Polypharmacy is due to multiple prescribers, which is secondary to multiple comorbidities. And polypharmacy may present a risk of errors and adverse drug reactions and serious reactions in the elderly. Approximately 10 to 17% of elderly admissions to ER are due to adverse drug reactions. And drug-drug interactions are more likely to occur when there's more than 6 medications. And polypharmacy, in addition to the risks, it reduces the quality of life of the patient and also can lead to a prescribing cascade when we have a symptom related to a second effect or an undesirable effect of a medication. Often prescribers may have this intention to add another medication, and we will have a prescribing cascade. So how can we manage these medications at the elderly? One key factor to managing medications is to have what I call a big brown bag checkup. Ask for the patients to bring all their medications at each consultation, and without forgetting to ask them about the over-the-counter medication, and especially in our region, to ask them about the alternative treatments that they receive. Another key element is de-prescribing, especially when the end-of-life period or when death approach, many medication becomes unnecessary and their side effects become more a risk compared to their benefit. So it's advised to have a patient-centered approach and to simplify the orders for the patients, the order of the prescriptions. There are tools that may help us in the geriatric populations to manage these medications. We can use the Beers criteria, which is a list of medications to avoid in the elderly. This list contains more than 41 medications, and it's always updated by the American Geriatric Society. Here I only listed a few medications that we see often in the palliative care settings. For example, try to avoid to prescribe anticholinergics for the elderly patients because there's an increasing risk of cognitive decline and delirium. If you want to put benzodiazepine, try to put a short-acting one. And of course, at the end of life, discontinue the statins, try to reduce the antihypertensives, and so on. Another complexity in the elderly is cognitive decline. The prevalence of mild cognitive impairment is 10 to 20% over to 65 years old, and this number increases with the age. Cognitive decline impacts the daily life. Loss of autonomy causes frustration and memory and problem solving, and communication problems may increase the suffering in the elderly. And the mental health is also affected with this cognitive decline. So just to talk about the palliative care in the dementia population, dementia is a leading cause of death in the elderly, in addition of its morbidity and or increasing number of that it causes in entry to institution. At the end of life, most of the people who have dementia, they die from the complications of the dementia, including aspiration pneumonia, urinary tract infections, or the skin breakdown. And dementia at the end of life, it also implicates critical decisions, such aggressive interventions may do more harm than good in the late stages. And it induces ethical discussions about artificial hydration, nutrition, and the resuscitation. And it creates a challenge for the decision making. So one of the key factor to accompany patients at the end of life with dementia is to do, as a palliative care physicians, the advanced care planning. And it's crucial to understand the evolution of the disease to help them, help their family most. So it's crucial to begin the advanced care planning very early in the stages of the disease before the patient loses his capacity of deciding. Another complexity in the elderly patient is the mental suffering. The mental suffering and the emotional suffering is responsible about almost the third cause of global suicide in the population. The prevalence of mental health issues in the elderly is around 10 to 20% for anxiety and depression, according to the WHO. But other studies highlight that up to 28% of older adults may suffer from depression. Mental suffering, they have a huge impact on the quality of life because they increase the cognitive decline, the social isolation, and also there's a vicious cycle effect because of these symptoms. But here again, mental health issues like pain and other distress in the elderly are under-recognized because older adults often view insomnia and fatigue and anorexia as normal aging symptoms. And this creates challenges in the assessment, especially with the cognitive impairment. So to help us, so it's crucial for physicians to assess the mental health conditions and to search for it, and you can use screening tools for this. Another aspect of accompanying elderly patients is the crucial role of the caregiver in geriatrics. The prevalence of caregivers among the population is high. Studies show that in USA, for example, 21% of adults are caregivers. And caregivers play a critical role in the care. As important as prescribing a medication, we need also to make sure that the caregiver is with us in the same line. So it's important as physicians to acknowledge, to support the caregivers. But caregiving is not without risk. In fact, many studies show that there is a big burden to be a caregiver. Often caregivers are sandwiched between their duty of being accompanying their parents and accompanying their children. And this gives a lot of emotional and physical strain. And there is a risk of increased morbidity when we are a caregiver and increased premature mortality even. Especially in dementia, caregivers may have 60% higher risk of developing major depressive disorders than non-caregivers. So the strategies for caregiver support in palliative care is to improve caregiver-provider communication. Studies have shown that this reduces errors and stress and improves the family satisfaction. We can also offer support for the caregivers, and this will reduce their burden and stress and improve the outcomes of the patients. And of course, we can use the resources available and to involve the multidisciplinary team to accompany the caregivers. Being elderly and elderly in the palliative care comes also with ethical considerations. The principle of autonomy, maybe we can have challenges in respecting the principle of autonomy at the end of life. 40% of elderly lose decision-making capacity before death, and only 30 to 45% have advanced directives. And the principle of non-maleficence also is involved because aggressive interventions often yield poor outcomes and hospitalizations may increase suffering. Thus, the importance of having advanced directives and especially at the end of life period, many conflicts arises between family members and we have family disagreements. Another aspect of complexity in the elderly patients is the uncertainty in the prognosis and the outcomes. In fact, prognostication in the elderly is challenging, and this is because multiple comorbidities affect the prognosis. And also there's a variable disease trajectory in the elderly. For example, if we take the case of dementia, the median survival is about 4 to 5 years. In contrast, patients who have congestive heart failure may have a survival rate or median survival time between 1 to 10 years, depending on the evolution of the disease. And there is a critical impact of the frailty on the prognostication too. So what are the best practices to navigate complexities and uncertainty in the elderly? First, do a holistic assessment, comprehensive assessment addressing the physical, cognitive, and psychological and spiritual factors for patients may help us to improve their quality of life by the end of life. Involving the interdisciplinary team is a key. And of course, we should pay attention to involve the family and the patients when early to make a shared decision making, and try our best to provide a personalized care goals. So in conclusion, with the evolving landscape and with the aging population and the increase of serious health suffering, it's important to integrate geriatrics to palliative care. Holistic and interdisciplinary approach are crucial, as well as communication, improving the communication with the patient and the caregivers, and to support the caregiver. Thank you for your attention. I would like to have your experience about this topic during our panel discussion. Thank you.
Thank you, Doctor. It gives me pleasure to welcome the final speaker in this section today, Ms. Virginia Handley, who is a cancer coach and will be introducing herself in a bit more detail when she comes to the stage. We're very fortunate to have her here talking about the patient perspective. Welcome, Virginia.
Hi everyone, I'm Virginia. I'm a cancer coach based in Dubai. I want to say thank you to Dr. Neil and his team for inviting me to speak on behalf of patients in the UAE. So I have 10 minutes. What I thought I'd do today is give you a summary of what it feels like from the patient's perspective, collective patients, to be living with a end-of-life illness, and then to say what we feel that how the medical profession can help. But I'll begin with me. I was born in the 1960s in Singapore. I was very fortunate. The impact of the environment around me was a very positive influence. Singapore was a small nation, entrepreneurial, emerging economy, startup. My earliest memory is walking down the road, holding my father's hand, and he said to me, "Look at that man running that street stall over there. Last week, he was over there selling egg bread. Now he's over here this week selling fried bananas, and he's got so many more customers. I admire him. He didn't give up. He kept going." So that was an early introduction into the resourcefulness and ingenuity of the human spirit when facing immense difficulties. In Singapore, no victimhood allowed. Adapt and be proactive. Fast forward to 2010, I was diagnosed with a type of ongoing blood cancer, stage 4. And my childhood early imprint really helped me. I'm the type of patient who wants to know all the details, researches their illness, and wants to make medical decisions with my healthcare team, with my doctor. I want to share the control. That's my personality. But human beings, we're all different, right? And I've been around a lot of patients who don't want to know any details of their illness or their medication. They want doctors and nurses to just give them instructions. And that helps them feel more secure. And that works for them. However, in my work here in the UAE with end-of-life patients, whoever they are, they all share something in common, and that is the fact that they are going to go through very strong, traumatic, emotional and practical challenges, no matter who they are or from what socio-economic background. So if we look at shock here, this one, sorry, I'm stepping away there. I'm so scared. This is the biggie. This is what patients say to me. I'm terrified. I'm so scared. I don't know what to do. It's very difficult to imagine what that feels like until you've been given a terminal diagnosis. We can't imagine until we're put in that position. Anxiety is another very big theme. So 85%, as Dr. Neil said, of people who live in the UAE are expatriates. Reliance on medical insurance for their job. Quite a lot of them lose their jobs when they become very ill. This has an enormous impact, catastrophic, on them and their families. It causes immense anxiety. So this is a major one. And the second major one is, will I be able to control the pain? There's immense fear about the pain that they're going to go through. These things are really felt by all end-of-life patients in various degrees, and I felt some of these sentiments myself. And what I do when I support patients is help them work through these emotions, process through them so they don't get stuck in them. Because if you get stuck in these emotions, anger, guilt, depression, it ruins the quality of life on a daily level that you have left and prevents you from enjoying time with your family or small joyful moments that happen in your life, or indeed doing the things you can still do. So, what to do? What can be done? What end-of-life patients say is that there are some key things that healthcare teams can do to help them live with quality and dignity. And these key things need to all happen together at the same time. This has come up a lot throughout the day, but get to know the patient as an individual. See the person behind the illness. Is this patient someone who likes humorous banter? Is this patient someone who needs lots of compassionate care and reassurance verbally from you? Is this patient someone who wants you to just sit with them quietly? Do you know how the patient wants to spend the rest of their days? Do they want to stay in hospital or do they want to be at home? Do you know what they want to achieve in the time they have left? So get to know us as individual people. This second one is really demonstrating that you care as healthcare professionals. So if we are in a panic or the ups and downs of end-of-life physical illness, sometimes there's a crisis and no one's clear about what the symptoms mean, everyone gets in a panic. You or someone in your team doesn't have to be the doctor, but needs to be fully contactable, and you need to get back to us quickly. If you don't, it increases our anxiety level and causes stress, not only for patients, but for families. The third one is someone in your team, if you doesn't have to be the doctor necessarily, the doctor who's responsible for your case or in charge of it, but someone in the healthcare team providing the end-of-life care to the patient needs to be skilled and talented at giving emotional care in the moment. So when the patient is going through their most difficult hour and they are feeling the terror of end-of-life potential hovering in front of them, a healthcare professional who knows them well, who is able to sit with them and talk to them and give them a sense of, you're not in this alone, we're in this together. Again, I said it doesn't have to be the doctor if the doctor is not particularly skilled in it. We all have different gifts, but someone in the team needs to be dedicated to do that. This is a really big one. It's help us to trust you medically. We're not talking about medical competence. That's a given, right? What we're talking about is the medical team demonstrates joined up, organised care, where every individual member of the team communicates with each other and keeps each other up to date. Otherwise, our trust levels go down, and again, we feel stress and anxiety, and so do our families. So when the radiologist turns up to talk about scan results, the radiologist in the team needs to have been updated on what your pain level's like, what your latest other test results are like, and basically what's going on for you. So help us trust you medically. A stage 4 colon cancer patient who's hospitalized for breathlessness and the family are panicking, she needs a stoma nurse in that hospital to help her and a pain specialist to help her. Don't advertise that you can help colon cancer patients and provide medical care for them unless you provide that. To follow up, priority on a daily level is pain relief. For an end-of-life patient, pain changes everything. You can't enjoy anything. And so a pain specialist needs to be in a palliative care team, and they follow up on a daily level with the patient and the family and keep an eye on what's going on. And for a lot of the cancer patients that I work with, they need hands-on practical assistance all the time in liaising with medical insurers here in the UAE or applying to charities to even fund their pain care medication because they've lost all medical insurance cover. The families and the patient need help with the before and after legal bureaucracies that are associated with end of life and depending on what country you come from. That's very important that there is a resource for that that's always available and accessible. Also, for all the patients and their families, what's really appreciated is a personalised, customised package of the kind of support therapies they want to help them. Not just talk therapy, that doesn't work for everybody, but art therapies, time out relief activities for families and carers, time out in nature, for example, and also access to a religious representative from the faith of that patient and their family, because that might be important. So if we look at the things that patients say help them to live the end of their lives with quality and dignity, we can see we can do this. In the UAE, we have big visions. historically, and we make them happen. So this is a concept, if you like, for joined up medical, psychological, spiritual, holistic, palliative care service, operating in tandem all the time. I want to say something briefly about the importance of hope. So even if you have an end-of-life diagnosis, there's still a need for a daily level of hope and to live with that. Because hope is a motivating emotion that helps human beings find the stamina to enjoy the small things in life and to carry on. This is a lovely poem from Emily Dickinson, and for me it says everything, because all human beings, we can't afford to give up hope, even if we know that our end is coming very, very soon. So I work with cancer patients and end-of-life patients on cultivating hope, the hopes that are individual to them. So end-of-life patients, hope is tricky, isn't it? Fantasy hope can lead to dangerous medical treatments that cause more harm and are destructive, cause a lot of distress to the family and don't work, and they may even hasten the end. So we cultivate what's called realistic hopes. So for one patient, it was that she was able to, in the last few days of her life, sit in the wheelchair on her balcony and listen to the birds in the morning, and that was her daily hope. So realistic hopes, what do they look like? These are some of mine. So the first one, this is the type of hope that I cultivate on a daily level. I hope for excellent medical care and to live with meaning and purpose within any new boundaries I have. Sometimes I can't walk. Sometimes I'm in too much pain to get out of bed for 3 weeks. Sometimes I can't move my fingers. My eyesight goes down. But I can still hope for that. If I'm in a lot of pain that's completely debilitating and overwhelming, I hope for a decrease in pain and to enjoy the things that I can still enjoy. Yeah, I can still enjoy talking to my husband even when I'm in pain. And when I've got new symptoms or I'm waiting for test results, I hope for accurate news, because with a lot of blood cancers, scanning, PET scans, you can have a lot of false positives. So for me, hoping for accurate news that gives me the truth about what's happening is important. So these are the types of hopes that work for me. Finally, I just want to end with saying that listening to end-of-life patients is a great privilege, because they express what they truly feel to me. But we know that nurses and doctors and a lot of other healthcare professionals who interact directly with patients bear their pain silently. So the patient vision of a holistic, joined-up palliative care service available to everyone in the UAE, no matter what their economic status or community they come from. That includes healthcare professionals in the centre of that circle of stones. So the prevention, the treatment and the recovery from medical professional burnout from trying to help us and be effective with us. We recognise that you work really hard and you have all kinds of pressures on you. So a palliative care service that meets the needs of everybody, including the healthcare professionals in the centre of it. And the patients I work with asked me today to say thank you to all the doctors and nurses, radiologists, every healthcare professional that's here, for everything that you do for us. So thank you on behalf of them.
Could I ask the panel to return to the stage, please? Just for questions. Sorry, Virginia, I should have stopped you leaving. Dr. Neil, is that okay? Thank you. Does anyone have any questions? Come to the stage anyway. Hey, we have a question on the side. Thank you, please. Are yours working?
It's working? I can speak now. The question is for Dr. Hamad, actually. Work with geriatric patients in Canada and here with pediatric. I think there's two populations that are quite similar, I find. The children with severe neurological disorder, not communicative, with high needs for care, G-tube, sometimes they have trach, the total care at home, and those patients with severe dementia or a lot of comorbidity that are severely sick. And unfortunately, my question is there a place for palliative care physician and specialized nurses also to get more involved into preventing what we see right now, which is we often end up seeing these patients, these children, these adults in ICU setting. They end up there. Sometimes it's causing a lot of distress, especially to the nurses. We hear these cases, a 95-year-old going through 3 rounds of CPR, being trach and TPN, and we know in children is the same story. And these are things that have been happening often, like several times over the last month or even year of their life, and they keep having this sad trajectory where we harm them repetitively. And my question is, there more role for specialized physicians and nurses who are actually trained in having these difficult conversations? Because often what we hear is, this is not my problem, this should be discussed by the primary team, primary physician. And I mean, I have a different view on this. I think it should be more a collaborative work, but I'd like to hear your word on this, this idea of advanced directive and the role of the specialized palliative care team in collaborating in these things.
It's working now. Thank you, Kim, for this excellent, relevant question. Indeed, you are highlighting the suffering the patients, elderly or pediatrics, they endure when they have unnecessary treatments and active treatments at the end of life. And I think that we as health professionals, we have a role in convincing and informing patients and their relatives and having honest and clear communication with them about this. But we do this daily. But there are other factors, maybe highlighted by Dr. Neil earlier, societal factors. They have high expectations sometimes. And also when they don't want also to adhere to our plans or advices, maybe we need to take more time to sit with these relatives and patients, because underneath this, maybe they have suffering inside. They don't want to feel that they abandon their parents. So if we take the time, we see that something is hidden about the caregivers. And if we address their fears about this complicated situation, and then they will adhere to our advices and plans, I think.
Any other questions?
Just a comment on collaborative working. I think it's really, really important that we try and come on the same page, because I love oncologists a bit, but they are optimists. okay? So we've had, situations where oncologists will come and they don't, I don't know, I've been in an A&E where there's a patient with advanced stage 4 cancer who has come in and they're on kind of, the last stages of life. And these important critical decisions needed to be made. And I felt it would be better coming from a person who has been dealing with this patient for the last 6 months rather than the total new guy who's walking in and having to broach this subject. But sadly, I was left with that, to deal with that. So I think having the honesty and ability to have that conversation, sometimes it is very, very difficult because you are the one that is giving people hope, and to be the one taking it away, that brings to the topic of multiple sort of futile treatments. And when you come from a side and you're the one having to say, look, I think we are at a different stage in this illness trajectory and we have to take a step back and reevaluate, that can be very challenging. So hopefully all of us will be able to work in collaboration and do the best for our patients. Thank you.
Okay, can I add something? So I just, in relationship to what's just been discussed, so I remember clearly a sentiment when I started palliative care training, which wasn't that long ago, but when we started, there was a very clear, to me, perception that the oncologists are bad at having these sensitive conversations. So this was, we have to, you shouldn't feel put upon. This is what we do. You can't expect the oncologist to do that. But as in life, that is an oversimplification. You've already alluded to it, Nuwan. So if as an oncologist, you've been seeing this patient for 18 months, 2 years, doesn't matter how good your palliative care doctor is or palliative care team is, we're a complete and utter stranger. They want to hear the news, good or bad, from the person or the team that they know best. However, we also recognize, and this has changed my practice, is that you think, well, okay, and many people have alluded to this today, everybody has a different skill set. I'm good at something, somebody else is, so I think, nothing of calling my colleagues in ICU and say, I'm going to have this conversation with a family. I really think it would be helpful. I'll brief you beforehand, but I need you to be there. You may not need to do anything, but the mere fact that the ICU doctor is sitting with the team, the primary team, reinforces the fact that ICU, which is seen as the pinnacle of care, actually, Dr. X agrees. Yeah, mom is best cared for on the ward. So there is something about collaborative working. There is something about framing the conversation correctly. And there's, like any of these things, the earlier you start the conversation, the easier it is to make that transition. But then that brings into question, how good are people at recognizing when the patient deteriorates? Very poor. So there is, we have to get better at recognizing when patients are deteriorating. And we have to go that step further to say, listen, I know this is what is happening now. This is what I'm worried about. The language that we use is so important. So people make fun of me at work because they think my language is it's qualitatively different. I said, but the reason we speak the way we do is because we have to be absolutely crystal clear. There is no room for ambiguity at the end of life, or when you're really worried that that patient in front of you is going to die fairly quickly, and the primary team or the family have no idea what's going on. So it's the whole spectrum of care. But if there is something that we are good at, it makes complete sense that we should support our colleagues if that is a skill that they're uncomfortable with. This is the only way collaboration will work.
Can I just say something there? I've been in situations with families of patients who don't really understand what's going on. It's been said to them, but not in a clear way, so they haven't grasped it. There's all kinds of misunderstandings going on. And maybe the orthopedic surgeon who's had to operate to take a tumour out of the leg of a patient is there, and he's the only one there that day, and the family are freaking out. So they call me, so I've gone into the hospital, and said to the surgeon, I know you're not comfortable saying this, but tell me what's going on. So he does, but the family won't hear me, they can't hear me, or I don't want to say it like that. So because the family then know me, I sit in the room with the surgeon. The patient isn't even his, but the family and the patient need to know what's going on. So I will say the words that the doctor can't say in a kind way, in a clear way, and he will affirm, yes, that's right, that's right. And then the family hear and begin to grasp. And as Neil said, the earlier it's said, actually, the better, because then it has to be said again in a different way a few days later, and then the following week and the following week. But eventually, the clarity of the picture of what is known from the evidence, that this is the situation and this person is best looked after without any further treatment options, can get through.
Thank you. There was another question on the floor, please.
Hi, good evening. Myself, Srirag. Actually, I'm not a person from a health industry. So, first of all, thanks to Ms. Mirjina Hanley, because you are really a great inspiration or motivator for all of us, including not only a volunteer, but for the caregiver, for all the doctors and everything. Heads off to you, first of all.
Thank you.
Yeah, and my question is to Dr. Neil. You talked about the session about this natural death for the patients. As a common man, you know, there is a common talk that the health industry is the highest paid industry in the world, because it is making a lot of money from the health industry. It's just a question. Just a question. As you know, if you're in UAE, you can, you know, if you are not having any insurance, we have to pay high expenses for our treatment and everything. My question is, how often BMC or other hospitals will suggest to the caregivers or the bystanders of the patient about the use of artificial supports like ventilators? It's not a good. It's not good to the patients for giving them a good end of their life. How often you suggest in your hospitals or other? How you understand?
Okay, that's a very, very broad question. I will try and answer it. I apologize if I got the wrong sentiment. For our team, and I've only ever worked for Bajil, so I can't speak for other providers, but in Bajil, with our practice, once we start interacting with a patient, and it is clear that that patient is deteriorating, and we are worried enough that that patient is sick enough to die, that's how unwell they are, we have a conversation. It may be conversation 1 of 7, but we start having the conversation, because you need to prepare the families. If they've come in, dad has been walking, he may have had a lung cancer, undiagnosed, but he comes in now coughing up blood, HB is 5, very, very breathless. If we don't do something quickly, he may not survive. And we see this day in, day out. So you have to prepare people. An extension of that is when we start having these conversations. For example, if somebody is deteriorating and they are coming to the end of life because of their condition, cost doesn't come into the initial conversation. It is something that we will often bring up later to reinforce the point. And yes, we work in private sector, and I'm part of the senior management team in hospital. I can tell you, within our hospital, we have 47, as of yesterday, long-staying patients. Patients who've been in hospital 3 months or more, each accruing almost $1 million dirhams worth of healthcare cost, which we absorb as a provider. Despite that, the conversation is not like this is costing this much. No, no. What we try to say is, yes, we can do X, we can do this intervention, we can do that intervention, but as doctors, as healthcare workers, we have to ask ourselves, just because we can do something, is it the right thing to do? How is it going to help the person in the bed? So how will it help mum? How will it help dad? If we do it, this is what her care would look like moving along. And part of the implication of that sort of more aggressive care, there's a cost implication. So people need to be aware of that. So I hope that answers your question.
Can I just say that I'm involved in a lot of hospitals in Dubai, including government hospitals, and they follow Neil's example generally, which is, is the care warranted? Before, how much will it cost? And then if it's very clear that financially the patient and their families don't have the funds for it, through the network somehow people find ways to help the family and the patients apply to charitable funding sources or get access cut price somehow. So people work within the private healthcare system, around the system and within it to optimize it as much as they can financially for that patient and the family. That's what I've seen here. It's very stressful for the family, but people, the healthcare professionals, individuals do try. And there are sources of funding here if you can prove need. It's just having access to them and being able to fill in all the forms online and get help with that.
But I will also add that patients come into a private hospital, they're seen in the emergency department, for example, and life-saving treatment is given, whatever your insurance coverage. Once the patient has been stabilized, and I can speak for Burjeel, internally, we may then transfer that patient, transfer their care elsewhere within our network, within the Burjeel ecosystem. And yes, we're going to lose money, but at least we lose money at a lower rate. The priority is still doing the right thing for the patient. We have and do spend an inordinate amount of time trying to support patients who have lost funding, who have lost coverage. But really, nobody gets thrown out of hospital. We do not do that. I have never seen that. And we have really complex, complicated, expensive care going on. Nobody gets thrown out of hospital. So, on the one hand, there are many, many things that we can do better in the UAE, but in terms of a safety net, at least there is a safety net. There is something there. Not a perfect system, but pretty good.
Thank you. Any other questions? Yes. Would you like a microphone?
Yeah, I'm just curious person. So just a philosophical observation for you. I have learned from my mentor, specifically Dr. Raj Gopal, and I have learned from Simriti ma'am, that when a person is diagnosed with a terminal condition, there is a huge wall between him and the normal world. So how do you feel about this? Is that wall too big? You can't see the normal side, other side, or you are just living your life in your new world, diagnosed with a terminal condition? What are your feelings about this?
I think it depends on who you are as an individual person. I talked a bit about my early life. It was very profound in shaping me. So 2 feet firmly on the earth in reality. However, when I was diagnosed with a terminal illness, really, that luckily I've been able to survive this long, it did bring up the spiritual question in a very deep way, which is what I think you're asking, which is, what is the meaning of this illness, etc., etc. Does it have a symbolic meaning? What's it trying to tell me? And it did change me on lots of levels, made me a much softer, gentler person. Before that, I worked in corporations at the top. I was very gung-ho, do this, don't do this, and it did change me. But for the patients I work with, it really just does depend on who they are and what they've been through in their life to what meaning they give their illness and their end of life. Some find peace at the end of life and acceptance. Some have a deep religious faith and they feel they're going to something else, or they've fulfilled their religious destiny. And some feel very sad because they're leaving behind children that they haven't had long enough with. You know, it's different for everyone. I will say that the love of family, love of friends, people being kind to you, people showing they care, this is very meaningful spiritually for people in end of life. So the importance of keeping yourself in a good state if you're a healthcare professional giving end of care life, so that you can always appear kind and gentle and have the energy to meet the patient where they are. This is important for all patients at the end of their life. What I've seen. Did that answer your question? Thank you.
Thank you. Any other questions?
So I just had one question and some comments as well. So my name is Emirates Sarpal. I'm a pediatric intensivist and pediatric palliative care provider from Canada, but I actually live in Doha, in Qatar. A few people have already commented that, you know, we're preaching to the choir here. Most people in the room are palliative care providers or believers in it and linked to it. There's comments about collaboration and trying to get our other colleagues to recognize that patients perhaps are struggling and maybe not in the, perhaps not in the position in their disease trajectory as we perhaps would like them to be, and maybe they're actually further along. I have my own opinion on this, but I wanted to hear the opinion of the panel of how do we, recognizing that health is about mental well-being, social aspects, the spiritual aspects, the physical aspect, all the other components that the WHO definition include, how do we get our colleagues to appreciate what we do and how this stuff can be integrated into mainstream medicine where so many more people could benefit? How do we take it outside of this room and spread it? What would be your guys' recommendations to people who are trying to develop services? Thank you.
Does anyone want to volunteer? Dr. Mohammed, would you like to, please? You can each say something.
It's a really, really good question. Is it working? Oh, yeah, sorry. I think two parts to my answer, and I'll keep it brief. Patients are more than their disease. They're more than their diagnosis. And I know this is cliched and everything's on the internet, but it is someone's mum, someone's dad, somebody's auntie in the bed. If you can't demonstrate in your actions when you're interacting with the patient and the family that you care, and I mean that in the most holistic sense, then it doesn't matter how good a doctor you are, you've already lost the battle. So one, you have to be compassionate and demonstrate empathy. The second part to the answer is the only way, I think, this is a pragmatic answer, the only way we can get more people to have a palliative care approach to care, which is what we're talking about, is education. There are simply not enough palliative care providers. I think before I came, it was something like 40% of palliative care posts, consultant posts in the UK were unfilled. That was 5-6 years ago. There's a global shortage of palliative care trained nurses and doctors. But actually, you know, palliative care is not the remit of palliative care providers only. It is an approach to care. There's really no reason, and other people have alluded to this, that we can't teach this approach at an earlier stage. Now, quite how we do that, I don't have the answer. I put up my hands. But it surely starts with us, those of us who have this training, being better integrated within the hospitals and the environments within which we work. So that's my kind of answer. I don't know how accurate it is. Maybe somebody has a different view.
Do you want to add to that? No, that's okay. As the moderator, I wouldn't. But I mean, I agree with Dr. Neil. I think that there's been a theme of collaboration and teamwork throughout the three talks today, actually. Dr. Neil's talking about the kind of higher end development of palliative care, Dr. Mohammed about the kind of interface between geriatrics and palliative care, even with polypharmacy and stopping people's drugs. I was thinking about how protective each physician is of the drugs that they've prescribed, and I stop a cardiologist's statin, and you know, that lack of teamwork, even in something as simple as demedicalizing or deprescribing, can be quite challenging. And then, of course, Virginia very eloquently talked about the patient's desire for how they're cared for, and a lot of that is about teamwork, collaboration, people talking to each other, so when the patient comes, they're not having to repeat the story every time, or the physician or the allied healthcare professional demonstrates understanding of the case that is before them, without the patient having to go over it again and losing trust. So I feel that this theme of collaboration and teamwork has threaded through the day, but certainly in this last session, it's been there. How we go about that, I absolutely agree with Dr. Neil. I think it has to be education, not only of our healthcare professionals, but of our patients and the wider community as well, so that they can advocate to have this kind of care provided to them. They come to hospital and say, I want joined up care, whatever that might look like. So that's my short answer for the end. Are there any other questions before we complete this session? Oh yeah, another one from the middle there.
Sorry for Dr. Neil, a hot topic to finish. So it goes also with Dr. who just had a question. So this is for the collaborator. And I think everybody agreed that palliative care is great. Nobody's going to say it's not great, like qualitatively. But we're working in a system that is becoming more private, you know? So we're talking about KPI, right? If you're talking with administrator or a CEO and things like that, and they're looking at length of stay, number of admission, number of visit, and we know that cancer patient at the end of their life, especially solid tumor, it's normal they come to the emergency, not because we're bad doctor, bad nurses, because this is the course of the disease. They have pleural effusion, we can't leave them home. So all these quality indicators are usually very resistant to palliative care. So even though we tell them palliative care is great, they will say, yes, it's great, but you guys are good, and it's even counting negatively for evaluation, you know, and your service and your performance. You see where I'm going. So I'm wondering, do you have any tips with your plenty of experience, how we can sell it so they can listen to it and support us despite having this framework of KPI?
That's a really hard question. My answer, though, is a story. So a couple of weeks ago, I was fortunate enough to go to Colombia as a part of a work trip. Bajil has initiated a collaboration with a company called Carolty that are based in the US and based in South America. Carolty's focus is on really well-integrated community-based services, primary care, mental health services, and palliative care in a value-based reimbursement framework. I mean, I spent a year or two looking at value-based stuff, and to me, this is the only way this is going to work. The current reimbursement models simply reward providers for doing more things. They don't reward them for doing what is right for the patient. So I was really humbled when I went to Colombia, because I was trained as a palliative care doctor in the UK. If you look at all the charts globally, the UK is always number one in terms of palliative care provision. That is slipping. I really was amazed by what they do in Colombia. So people in Colombia, or patients in Colombia, within the ecosystem that I saw, were able to move between the hospital, community-based health centers, primary care, the specialist palliative care units, and the hospice interchangeably without incurring cost at each interaction. And this company were able to do this and still make a profit. So Bajil is looking at doing this. We are starting a pilot project in KSA. This is the plan. We're also trying to do this with mental health services within Abu Dhabi. This is all in very, very early stages, but it's not easy because you're now trying to change an ecosystem, and the way healthcare services are funded, it is big business. So this is probably a cop-out, but this is the way I see things going. It's the only way it'll work.
Are there any further questions? Well, I'd like to thank our speakers for their enlightening talks today and thank the audience for remaining until this stage of the day. I believe we have one further session. Is that correct, Dr. Neil?
The last session for the day was meant to be an open mic session, open floor, ask any questions, which is pretty much what we've had. So I think we should, in the interest of quality of life, finish on time, unless people have issues.
Very nice.
Okay, you can all go home. No, I mean, go home today, come back tomorrow. Thank you. Thank you guys for coming, really. Thank you.